little bit about ulnar ligament tears. Obviously a hot topic in young athletes these days, especially throwing athletes, but it involves multiple sports. You see a lot more of these types of injuries with mixed martial arts and wrestling and things like that as well. So there's a little bit of a difference between the types of athletes that come in. This is a little side project. I'm going to worry about that. We're not going to do with that. So in the athletic population, what are the options for patients with ulnar collateral ligament tears? We really want to get back to the normal physical activity, and that's really one of the keys. Is what is their normal physical activity? Is it just weekend warrior? If I have a neurologist who tore his doing a zip line, it doesn't need it. It doesn't need surgery. It did very well with non-operative treatment. We have a high school pitcher. We have a college pitcher, a professional pitcher. It's very different than an NFL football player. So a little bit about overhead throwing. I'm sure you guys have probably seen a lot of these types of slides and this type of information before, but throwing a baseball or throwing a javelin, which is another common problem with these, is different than throwing a football because there's a shorter arc of range of motion in throwing a football, so you don't tend to see these in quarterbacks, but it results in a significant valgus stress across the elbow. And all this stress is really concentrated on the medial structures. When there's insufficiency of those medial structures, then you can have compression stress on the lateral side of the elbow. So that's a secondary problem that arises. The majority of these are related to repetitive overuse injuries. They're not usually related to acute traumas, although they can happen as well. Now, if you have an acute trauma, it's a little bit of a different animal, and we'll go through some of that later on, but the majority of what you read about, what you see, is related to chronic repetitive overload. Baseball pitchers and throwers are commonly most affected. Pitchers, for sure, are the majority of these. And medial elbow symptoms account for over 97% of complaints in pitchers. So a little bit about elbow stability, okay? Less than 20 degrees, meaning perfectly straight, to about 20 degrees, or greater than 120 is when the bone takes effect. And that's when it gives you the majority of the stability. That's what's supplying the stability of the elbow. When you come outside of that range and you're between 20 degrees and 120 degrees, which is really the throwing arc for a baseball pitcher, pitchers tend to get flexion contractures up to about 10 to 20 degrees sometimes, and it doesn't affect their performance at all. Really, that throwing range is 20 degrees to 120 degrees for overhead throwing. So the soft tissue are the main restraints for that, and that includes the muscles and the ligaments. The main ligament we're talking about here is the ulnar collateral ligament, or the medial collateral ligament of the elbow. And there's multiple structures that are involved in that, the least important being this transverse ligament, which just increases the sigmoid notch, doesn't really impart any stability to the elbow. The posterior bundle also does not impart any significant amount of stability to the elbow. It's really the anterior bundle that gives the majority of the stability. The anterior bundle is split into two bands, the anterior and the posterior band, and it's really the primary restraint to the valgus stress from 30 to 120 degrees. So the anterior bundle, okay, which we'll show you how to test for that in a little bit, gives you the stability up to 90 degrees, and the posterior bands from 60 to full flexion. And then again, during the acceleration, the late cocking to the acceleration phase of throwing is when you're going to actually stress this the most. And when pitchers are using this motion and they're back in that late cock and the forward acceleration, they're subjecting themselves to loads that actually exceed, on some levels, the ability of this ligament to hold that. Okay? So there's a lot of stuff that's going on. Otherwise, every time you throw a baseball, in some of these pitchers, they would rupture. So dynamic support is also very important, which involves the muscular control of the elbow. And so the posterior bundle is more vulnerable to valgus stress only if the anterior bundle fails. The anterior bundle typically fails first. Okay? And again, the oblique is nothing. So these are the stages of overhead throwing. The main things we're worried about here again are the late cocking and the acceleration phases. And some people are confused and they just create their own problems. So some of the biomechanics of it, again, it generates large valgus and extension forces as you're throwing a pitch. They can exceed up to 64 newtons of late cocking and the early acceleration with compressive forces of 500 on the lateral side. So the tensile stress along the medial structures is significant, and the shear stresses occur in the posterior compartment, and on the lateral compartment you get compression stresses. So what that can create is kissing lesions on the lateral side of the elbow, osteophytes that can form on that side as well. And together you get this valgus extension overload syndrome, and that's a more chronic issue. You have more chronic pitchers that have problems with the repetitive use when they're a little bit older, college age, not that that's old, but and professionals, you can then start to get some of these osteophytes when this goes on for a long period of time. If you get an acute rupture, most of the time you're not going to have that. Typically those are in younger patients anyway. There's a lot of things that can happen in the elbow with throwing, and so you can have UCL tears, partial tears, olecranon on tip osteophytes, loose bodies. These are all things that are going to be in our differentials. Flexor chordator mass tendonitis, ulnar neuritis, and apophysitis in skeletally immature patients. We're really going to concentrate here on UCL injuries. If anybody's got any questions or can't hear, just stop me at any time. So things you want to look for in the history: the changes in the training regimen, changes in accuracy, velocity, stamina, strength, time of onset of pain in the throw if they're having problems pitching, what phase it's occurring in, whether it's the follow-through. Those are typically different problems that will occur because you're in more extension at that point, and any neurologic or vascular complaints. From the exam, there's a lot of different things that we look at in the exam. Lateral elbow pain, you typically think osteochondritis dissecans in pitchers as well. You get kissing lesions on the lateral side of the elbow. Really what we're worried about here is stability. Okay? So things you can do on radiographs is plain radiographs, but what you really want to do is do a gravity stress test comparing both sides. So you put it into about 25 to 30 degrees of flexion, and there are some devices out there that can give you proper stress testing. They put about 15 newtons of stress across the elbow, and you can compare both sides. And really, if there's a difference in up to over a half a millimeter, which doesn't sound like a lot, it's not. That actually can show a difference, and that's been shown in certain studies. But you're really looking at, from a clinical standpoint, greater than 3 millimeters of opening on those stress review tests. So things that you'll also find, CT scans can be helpful, MRIs can be helpful, identifying olecranon stress fractures, bone scans, again, can develop olecranon stress fractures. Again, those are typically patients that you're going to see that are going to have more pain and follow-through of throwing when they're in full extension. Okay. And then talking about MRIs and CT arthrograms for the ulnar collateral ligament. Ultrasound is also becoming more in vogue. We have one in our office as well, and it can be reliably used to assess these structures, including the ulnar collateral ligament. What you're looking for here is the consistency of the ligament on the exam, as well as the medial gapping when you stress the elbow. Early changes that you'll see in pitchers that have chronic insufficiency or thickened ligaments, and you can also see calcifications in the ligament as well. So again, there's a difference between acute injuries, the sudden onset of pain with a pop when you're throwing, and they're really just unable to throw anymore, and that's when you've got an acute avulsion. And chronic injuries, where you've got more gradual onset of pain, you've got pain after throwing extended periods of time. We see a lot in young patients, typically the younger ones, the 11, 12-year-olds that I see in my office, are ones who, the parent missed a game, the coach didn't know they pitched earlier in the day or yesterday, and they get out there and they throw because the coach didn't know any better, the kid doesn't know to speak up, and they go over their pitch count. So they also tend to have ulnar nerve symptoms secondary to irritation, whether that's subluxation, or just a positive Tinel sign, or some numbness going into the pinky and the ring finger. So on the exam, really the three main things that that I do is, number one, is testing for the anterior band of the UCL. That's basically with the patient seated. You want to externally rotate the shoulder so you can lock it. You flex the elbow 20 to 30 degrees to unlock the olecranon from the olecranon fossa, and you apply valgus stress along it. As you're doing this, you're feeling the inside of the elbow to palpate the medial joint space and the ulnar collateral ligament to see if you can feel any gapping. If you lose an endpoint, just like you feel on an MCL or an LCL in a knee, you don't have that endpoint there, and you've got some joint space opening, you probably have an incompetent UCL. So more testing for the posterior band is what we call the milking maneuver, and that's when the elbow is flexed 90 degrees or above, and you're basically pulling on the patient's thumb with the forearm supinated and the shoulder extended. And you're basically, again, applying a valgus stress across that, but because it's flexed above 90 degrees, you're now testing more of the posterior band. Again, this has some utility in practice if you're looking at somebody who's got an acute avulsion. This can be positive. In some of the more chronic ones, you're really looking more for the anterior band that you're really assessing. So I find this to be of relatively limited value. Really, practically speaking, the simplest thing to do in your offices or in your training rooms and in mine is the moving valgus stress test, and this was described by O'Driscoll. It's very sensitive. It's relatively specific as well. And what you do basically is look for this shear angle between 70 and 120 degrees is typically when you'll feel the most pain. And what you're doing is you're basically hyperflexing the elbow, applying a valgus stress by pulling on the thumb again, and quickly extending the elbow. And so if you get that pain in that 70 to 120 degree range, then that's very sensitive for picking up an ulnar collateral ligament tear, whether it's partial or whether it's full. So I find this to be the most useful. Point tenderness, swelling may vary. Again, The epicondyle has a lot of attachments for muscles. You can get medial epicondylitis. You're testing along the sublime tubercle as well on the ulna, but these can be hit or miss depending on your patient. So that it's not always reliable. I think distraction techniques are very important when you're examining these patients to try to get them to relax, and so that they're not focusing on just, well, everything hurts over there. Really trying to focus in on two areas that are a centimeter apart, which one hurts worse. You're also looking for range of motion loss, especially with terminal extension, which you can find with chronic valgus instability again. So, in X-ray findings, this is just a gravity stress test example. You're at 20 to 25 degrees of flexion, and you're just allowing the elbow to hang off the table with the shoulder externally rotated and abducted 90 degrees. And greater than 3 millimeters is suggestive of opening, which obviously you have to compare that to the contralateral side. So MRIs are ordered a ton. I say the same thing when I do regular shoulder exams as well in patients, and I order MRIs. MRIs are really not very well done for wrist and elbow and shoulders. Really, I think MR arthrograms are much more important for these patients and for identifying proper lesions. The saline enhanced arthrogram is much more sensitive and specific than an MRI by itself, or even a CT arthrogram. That's sort of fallen out of favor with a lot of radiologists, especially in the area. Really just using gadolinium can be very, very helpful in identifying this. You can see partial tears where you'll see some leakage along the sublime tubercle, and you get what we call a T sign. These things aren't always picked up without getting that gadolinium involved. So it is uncomfortable, it is invasive, but it depends on the level of pitcher or athlete you're talking about and when to send for that. So an MRI is a very good, simple screen for it. You can also do an air arthrogram, but really for somebody who's high-level pitcher, I just send them for an MR arthrogram right off the bat because you need to know right away. So different treatment options that are out there. Some of them have been more time-tested than others. Conservatively, we're looking at therapy. PRP is now becoming more in vogue. There's a couple presentations at at the meetings, some posters. There's one publication on it that we'll go through. And then surgical repair and reconstruction. A lot of literature out there. There's no good evidence. And so again, we went through a little bit of this slide before as far as the grading of studies. There's really no good level 1 or level 2 evidence series that are out there for ulnar collateral ligament injuries. So you got to take everything with a grain of salt. Now there's very good papers out there, and there's very good reconstructive efforts that have been done, and there's very good success rates, but I think that's been overblown by the media and overblown by athletes and their parents because they're looking at high-level athletes, and if you're going to get 4 years out of an elbow, that's great when you're playing pro ball and you're making $5 million, $6 million a year. When you're a high school athlete and you're going for a UCL reconstruction, what are we really doing to these kids? And so really, I think prevention is really the key for these patients. So non-operative treatments really indicated in mostly non-throwers, okay? If there's partial injuries, you'll start conservative care, depending on the level of the athlete, obviously. If you're talking about high school kids, you're going to start non-operative treatment no matter what, initially, especially if it's a partial tear. And it has acceptable results in lower demand populations. There's a study we'll go through as well later that talks about NFL players, but again, we're not talking about throwers. So usually it's 2 to 3 months of rehab, non-throwing, splinting until the pain's improved, and the inflammation has died down, really doing range of motion and therapy of the shoulder, as well as the wrist flexors and the wrist extensors. You really want to avoid injecting the ulnar collateral ligament with steroid because that can attenuate the other structures over time. The main thing that you want to talk about here is the flexor pronator mass. That's really the most important dynamic stabilizer of the elbow. So we talk about static support, which is the ligaments. They don't change their size. They're not really contracting and moving, versus the dynamic support of a joint. The flexor pronator mass, especially the flexor carpi ulnaris, is the primary stabilizer. And the FDS, the finger superficial flexors, is really a secondary stabilizer. The pronator teres gives you the least amount of stability. Still, the anterior bundle of the ulnar collateral ligament provides the first stress, the restraint stress. So some of the literature that's out there, they looked at 18 NFL players with ulnar collateral ligaments. Every single one of them returned to play. The majority of these, I think there was one throwing football player that was in this, but again, you're talking about a shorter arc of range of motion, you're not really stressing across that ligament. Reddick found 42% return to play, 24.5 weeks after a diagnosis. Again, these mean age were 18 years old, all right? So you can get away with this type of treatment, but these tend to be younger patients you're going to be doing this with. They're going to have healthier ligaments. They're going to have ability to heal. So these are some of the things that you have to keep in mind when you're looking at some of these studies. you're looking at a 30-year-old, he's not going to heal like an 18-year-old. But they can get back even to throwing with these. So this is just a case series of 34 athletes. Again, this is level 4 evidence. This is not gold standard or anything like that. They're looking at ultrasound diagnosis. They were looking at joint space widening with ultrasound stress testing. And they found that after doing the PRP injections, there was less widening that they found on the repeat stress, and 88% returned to play. These are in partial tears, not full thickness tears. One of them went on to surgery. So there is some hope potentially, coming from this. PRP is the wonder drug, that I don't think we really have to, we're not going to be able to hold our hat to that eventually, but we'll see. I always take literature with a grain of salt when you look at it. Everybody has to get their name out there. There's a lot of pressure to publish in the academic world these days. And so we'll see where the pendulum swings. As far as direct repair, these are, again, very common. You can get away with this in younger athletes, such as mixed martial arts, wrestlers. You can do it as well in throwing athletes. The main thing you need to worry about with this is what is the status of the ligament. And so if you have a normal appearing ligament, it's an acute rupture of the ligament, this is a valid option, okay? You really only want to do these in acute traumatic ruptures without a dislocation and without ulnar nerve symptoms. And so in Richard's study, they looked at, again, very small numbers here. 9 out of 11 college athletes returned to play within 6 months, and it also worked even in throwers. And so you can repair these in certain populations that throw. You're not going to do that for a chronic insufficient ligament that's been attenuated, strained, partially torn. That's not going to heal the same way. Again, this is looking at 60 adolescent patients, all right, and it's basically looking at repairs of the elbow. Usually what they'll do is suture the ligament, repair it through drill holes. Good to excellent results in 93% of the patients. Again, these are adolescent patients. They're much less likely to have chronic damage. I have a video which I didn't put in. I couldn't cut it down to 5 minutes, so I think it'll be on the site eventually for the compendium. It's on a lacrosse player that we did a direct repair on, and she's done great with it. Again, these are less likely to have chronic damage. Okay, and a lacrosse player is very different than a thrower. Even in a 16-year-old thrower, you can get away with a direct repair from an acute rupture. And out of these, 50 out of 60 were able to return to their original level of play or higher within 6 months. So they do get good results. So what do we look at when we look at repair versus reconstruction? There's actually surprisingly not a lot of literature out there. Most of the docs are reporting their results, but not really looking at a head-to-head. And again, none of these are level 1 or level 2 studies, but really we're looking at return to play. And so Conway was one of the first in 92. Again, the first paper written on this was in 1986, so most of the literature is very recent on this. 50% in the repair group, 68% in the reconstruction. So this was relatively early on. For the major league players, you really want to reconstruct, and I think they proved that pretty clearly. There were 2 out of 7 in the repair group. But it's still not anywhere near 90% in this original study. James Andrews is a very big proponent of trying to stop pitchers throwing when they're younger and allow rest and pitch counts. I saw him talk when I was in Miami. He's a great guy. You've seen him on Facebook all the time now. I've seen him, trying to champion, trying to stop patients from throwing too much. He's really done a great job with it in pioneering this. His repair is really what's really recommended by the Society of Sports Medicine. So 0 out of 2 came back to play from his repair, and he went to the reconstruction, which 86% came back to play. Again, we're looking at 63% versus 81%. If you look at the overall literature, you're looking at mid-80s, 85, 84% that success rate in getting patients to get back to throw. The question is how long are they going to be able to do that for? All right. Typically, when you're looking at this, it's for 1 year. Is really sort of the endpoint that most of these studies look at. Really, you're looking to try to get something that's going to be greater than 4 years. This is a typical reconstructive technique. This was first described by Job in '86. Again, this was the first paper out there. It was a figure-of-8 graft. Usually, what we prefer to use is a quadruple palmaris tendon graft. There's a lot of other graft options that are out there. You can use if it's the throwing elbow, obviously, you can use the contralateral side, that you don't affect the wrist at all. There are some small percentage of patients that get complications from taking the palmaris. It's very, very few. Out of theirs, 10 out of 16 returned to play. These were all throwers. You can use hamstrings. The gracilis is a little bit bulkier, but it's not usually as long, so you can typically double that over instead of quadrupling it. I tend to prefer the palmaris. I'll go into, it's not in the talk, but Savoy looked at the different types of graft, whether you look at allograft versus autograft. So if you're looking at allograft where there's no donor site morbidity, and you're just taking it off the shelf, there's really no difference. And I think he's sort of a little bit of a pioneer in this regard. There's a couple of other studies that he's done on these as well, but he actually, had the energy and the desire to go out and prove that, hey, this works just as good as taking it from their own body, because there's a little bit of risk involved in that. And these were professional athletes that he's taking this chance with, when all these other studies are talking about autograft use from their own body. So allograft is a very viable option. The docking technique, which was described by Alchek in '96, is also a very common one that's done. Basically, two limbs are brought into one tunnel in the distal humerus there, and then you tie the sutures over a bone bridge. And it's been reported up to, again, 85 to 92% return to play, but again, for at least 1 year. So it's not really a great thing for a high school pitcher. Really, a typical post-op rehab is 7 to 10 days in a posterior splint. You just allow the swelling to calm down, you allow the incision to heal. It's then followed by active assisted, active range of motion. People are more aggressive, I think, getting the motion at this point now. You're really in a hinge brace after you get out of that splint for another 5 weeks. In 6 weeks, you can come out of that hinge brace. Really, you're looking at that 20 to 140 degrees. We're not typically very aggressive getting that terminal extension right away because, again, it's not necessary for pitching. But most patients have the majority of their motion back at that 6 week mark. And then you're starting progressive resistive strengthening during that first 6 weeks, just of the wrist and the forearm. You don't want to do any elbow strengthening at that point. You need to avoid valgus stress, obviously, during this as well. At 6 weeks, you can start to begin elbow strengthening. You're really still avoiding valgus stress to 4 months. Throwing programs typically start at 4 months. The one caveat to that I'll say is that if you do use allograft, off-the-shelf tendon graft, these therapies have been pushed out a little bit more. I think people are a little bit more hesitant to get them rehabbed quicker. And the time frames have gone back a little bit more on those. So you're probably going to start that at around 6 months for an allograft tendon. You condition the shoulder and the elbow progresses, and you're really trying to get them back between 9 and 12 months for throwing. Again, I typically say a year. For allografts, it's more, you say 14 months to 16 months, just because you want to allow that tissue to incorporate. So some of the clinical conclusions, basically injury to the MCL or the UCL is relatively common. There are a lot of other diagnoses that are out there though, and MRIs are not great at picking all of these up. Right? The stress radiograph can pick it up sometimes better than some MRIs. Really, a perfect clinical exam and proper diagnostic studies need to be utilized, whether that's ultrasound, whether that's MR orthograms. Again, if you've got a 12-year-old pitcher, I'm not going to send him for an orthogram, but if you have a high school pitcher, who's being showcased and looking at colleges, that's somebody you're going to be more aggressive in getting the proper study. Conservative treatment and rehab should be considered for injuries that don't really have any significant laxity on the exam, especially in a non-thrower. Surgical treatment has very good results for patients with valgus laxity, whether that's repair or whether you're talking about reconstructions. The repair should really be reserved for patients with acute ruptures, acute laxity, healthy ligaments without dislocations of the elbow or ulnar nerve symptoms. Reconstruction does have improved return to play and chronic instability compared to repairs. Some of the things I didn't get into fully, we just didn't have a lot of time with this, but is that really the two main take-home points from a surgical standpoint, and this has been throughout the history of the last 20, 25 years, is you want to decrease the dissection of the flexor coronary mass. So some of the original papers involve actually reflecting that flexor coronary mass, back here, off of the epicondyle here. It's literally pulled off the bone, you do your reconstruction and you repair it back down. The less you touch those muscles, the better your results are going to be. And so there's really a raphe that runs between that the posterior third here. And you'll be able to see that in the video that I have, where if you stay posterior to that, you can split the muscle and get a good view. Finally, decreased handling of the ulnar nerve. So the original papers with Andrews and Joe, they all transposed the ulnar nerve. There were up to 20% complication rates with needing to do something again to that ulnar nerve or having chronic ulnar nerve symptoms. So the less you touch it, the better. You leave it in the bed, you split the flexor coronary mass so that you can avoid going into the nerve. It does take a little bit of finagling, depending on what technique you're using as far as drilling your tunnels. You have to be careful. The ulnar nerve does run right behind that medial epicondyle. So you have to dissect it out and identify it and protect it out of the way. Obviously, UCL injuries can have significant impact on normal function of the elbow in most patients, but it's even more important in the throwing athlete. It's important to identify the subtle instabilities that occur with these patients on your exam and implement an appropriate course for treatment. again, partial tears, ultrasound capabilities are all becoming, more easily recognized in the office setting. And this is just another technique that's used as well with interference.
We have time for one or two questions.
Steve.
Steve.
Yes, sorry. What's the reasoning behind limiting like pitch counts of some of these athletes we see at the professional level? Is it the integrity of the graft, or is it just simply the potential fatigue because they...
It's the fatigue. It's really fatigue. And that's where, really you're looking at 100 pitches, especially in younger patients. So it's not just patients who've been reconstructed, it's pitchers in general. Because again, that's typically what I'll see in the office is if somebody comes in, they forgot that they pitched the day before, the parents weren't there, somebody else gives the kid a ride to the game. Hey, listen, we need you to get in there. They throw him. Didn't realize that he threw previously, so you're looking at 100 pitches. You're really looking at 100 innings per year is another major rule that you want to try to keep in mind. And it's really that chronic fatigue that goes on. Number one, the muscles get fatigued. That puts more strain on it. So if you've got any secondary restraints that are there with the flexor coordinator mass, the FCU, you need that working. And if you're getting fatigued and your endurance is down, so that's why the endurance is also important to maintain for all this. I used to play a lot of baseball. I went out to college. My elbow kills me now. I used to take 3 Advil before every game. Nobody knew about this stuff when I was playing high school baseball. I never worked on wrist flexors and finger flexors and things like that. So I think that's some of the things that we can really do to help our patients earlier on to try and help prevent some of these injuries. So.
Chris, do you think switching position is a viable option for like a teenage pitcher with symptoms and a partial tear, say? Switching to a shortstop, is that?
I usually, for example, we have an old PA who used to work with us, and his kids are great at baseball. I said, just put him at second base, and he just stopped pitching and let him pitch, last year, high school, college. To me, that makes the most sense, to be honest with you. They're still playing, they're still loving the game, they're still learning. I played with a lot of good players going through. There was a guy who threw 96 miles an hour when I was in high school. I played on a touring team with. The guy never made a pro. These are the guys that throw their elbows out. So I really think, pitching at a young age repetitively. My kids don't play baseball now at all. I don't want them throwing because if they want to play it, they'll play it later on, but their elbows will be fine. So I really think limiting the amount of throwing that goes across with high strain makes a huge difference. So if you're throwing a shorter distance from second base, I do think it makes a big difference. So.